Good morning, dear colleagues. It's my pleasure to present you my clinical case. I would like in the beginning to thank organizers for giving me this chance. I hate conflict. I don't have potential conflict of interest. Behçet disease is an immune-mediated systemic vasculitis with oral and genital ulcer manifestation affecting skin, eyes, central nervous system, and musculoskeletal system. Arterial involvement is less common than the venous one. The frequently involved arteries are the abdominal and thoracic aorta, pulmonary, iliac, and femoral arteries. Coronary arteries are rarely affected. Only about 20 cases have been described in literature. Etiology and treatment are yet unknown for the moment. Our clinical case is about a 33 years old male with history of Behçet disease in remission. He is cannabis user and he is in jail because of cannabis traffic. He presented with a posterolateral STEMI, thrombolized successfully at age 2 of pain. His echo showed an ejection fraction at 52% with limited posterolateral hypokinesia. He is admitted in our hospital for coronary angiography 12 hours after thrombolysis. The angiogram done with right radial axis show a 111 mediana lesion on long circumflex plaque with an important aneurysmal pocket, as you can see here. At that moment, we have only two very long graft masters, 26 millimeter, TIMI3 flow without chest pain, so we decided to stop the procedure here to perform a coronary CT and order a shorter graft master. The coronary CT done 1 day after show very important aneurysm tied to the circumflex artery with a large collar, as you can see here. 3 days after, the chest pain relapse with ST depression and troponin rising. We come back to the cath lab. The aneurysm seems to be worsening. We have a TIMI1 flow on the circ and optus marginal. So now we need to keep everything open. We plan to perform a double stenting PCI for this very important bifurcation. So our plan A was to perform culotte technique alone. Maybe the double layer of stent could be able to exclude the aneurysm. Plan B was to perform culotte and wait for the right covered stent length or implant a coil inside the aneurysm. And plan B was to use available covered stent and sacrifice one of the coronary branches, especially if perforation during PCI. So we decided culotte technique. We wire both optus marginal and circ. We perform balloon dilatation with Minitrack 2.520. We implant our first drug-eluting stent from the circ to the optus marginal. We perform POT, opening strut. We retrieve the optus marginal wire and we implant our second drug-eluting stent. We perform POT and then opening strut of the second stent, kissing and final POT. And this is the final result. We have a TIMI3 flow on optus marginal and circ. The aneurysm seems to be smaller, but it's always patent. Patient is stable, TIMI3. ECG is normal, no chest pain. So we decide to stop at that moment. And 1 week later, we control the patient with a radial axis. We have good result on both circ and optus marginal, and the aneurysm seems to clot at that moment. The patient is stable, ECG is normal. We don't have data, so we use what we know about angio-Behçet. So we put him under aspirin, clopidogrel, and rivaroxaban for 1 month. We have no data about rivaroxaban, but we were afraid about ENR control in jail. We put him also under prednisone. We plan to perform a coronary CT 3 months after, and the extension assessment was normal. So coronary Behçet is rare. Most cases are seen in young men. It's 7 times more frequent in men than women. It's occurred between 30 and 50 years old, and it's facilitated by smoking. Mechanisms of ACS in Behçet can be thrombosis or coronary crushing due to the aneurysm, or coexistence of atherosclerosis disease. PCI can be dangerous because of the high risk of rupture. Delayed endothelialization requires prolonged anticoagulation, and corticotherapy may reduce instant thrombosis. For our patient, in the first ACS, the fibrinolysis success leads to coronary thrombosis due to plaque rupture and or coronary compression by the aneurysm. For the second ACS, the aggravation of the aneurysm may be due to reduction of the coronary flow by rethrombosis. The aneurysm in turn compresses and reduces the coronary flow. And this is what happened after culotte. The aneurysm is small and then it clot. This case demonstrates the necessity of regular coronary non-invasive checkup in Behçet disease patient. And to be totally honest with you, 2 days ago when I arrived in Paris, I received an email telling me that the patient stopped the all treatment. He presented a non-persistent ST elevation myocardial infarction with quick cardiogenic shock and death. It demonstrates and highlights the delayed re-endothelialization of the stent and the necessity of maintaining a long-term anticoagulated therapy. Thank you.
Thank you very much. A very impressive, very interesting case. Any comments from the audience? Comments from my colleagues to the right?
The problem of the duration of double anti-aggregation for this patient or anticoagulation for a long time, I think that's that isn't clear.
Yeah.
There is no consensus, but I think that the problem of the Behçet
especially
is the most important to treat, and I think in Tunisia we have not a lot of such patients, but we keep them with anticoagulant treatment.
When we search in literature, we found small studies about angio-Behçet, not coronary Behçet, and they said that we have to keep double antiplatelet therapy and anticoagulation between 1 and 3 months. And he died 4 months after PCI. We maintain it, but he stopped everything. He is in jail, he has problems, so he stopped everything.
I mean, here we have different problems
all
put together into one patient. It's coronary aneurysm, the underlying disease that we don't know much about. What do you think eventually, because what are the options here? The options he described very nicely. You put a graft master in. The graft master wouldn't eventually change anything to exclude the aneurysm. Most likely, I think we know that you don't need a graft master in order to get thrombosis of the aneurysm by just conventional stenting, which might be advantageous due to the size of the circumflex artery. You can do the coronary stenting, traditional stenting with culotte in order to reduce flow and eventually thrombosis. But what do you think happened eventually? Why did he have a reinfarct? Was it thrombosis again?
The last one?
I'm sorry. Was the reason the culotte in general, or was this culotte and Behçet disease?
You are speaking about the last event,
yes.
The death. I think that it was about the culotte and the Behçet. Because in the Behçet we have a delayed re-endothelialization of the stent.
Yes.
We put 2 layers of stent,
yes.
2 stents, and he stopped anticoagulation and antiplatelet therapy. I think that it's the association of culotte technique and Behçet. And stopping.
Do you think that if you hadn't done culotte, simply as you suggested, your option,
covered stent,
sacrificing the side brain, do you think it would have changed anything in retrospect?
Really, if he stopped antiplatelet therapy, it will be the same issue.
Same outcome.
Same issue.
So maintaining.
Yeah, of course.
Good. Any other? Yes, please.
Actually, just to follow on what you're saying, I think for me, you've done a fantastic job. However, in a case like this, I probably would have avoided culotte because there's an increased risk of thrombosis with the aneurysm. It wouldn't have been much better to just put a stent in the circumflex and treat the diagonal just with a balloon, just to reduce your chances of this happening. Whether if that will help reduce the chances of if he stops the antiplatelet or not, we don't know. But having a double layer of stents and clot probably increases the risk of thrombosis.
And you know, the decision was easy because the patient decided for us. We don't have a small graft master. We have an acute coronary syndrome, TIMI1 flow, so you have to do something. And decision was easy at that moment.
Yeah, please.
If you are going to use the graft master, which branch are you going to sacrifice?
Oh. If I can show you the first angio, for me, I will sacrifice the optis marginal.
Sorry?
For me, I will sacrifice the optis marginal because the territory of the circ is bigger.
In this case, don't you prefer to implant a bare metal stent in order to stop DIPT as early as possible?
Thank you for the question, but you know, in Behçet disease, you have a high risk of restenosis. So with bare metal stent, you are sure to have restenosis. But you have to deal between thrombose or restenosis.
Yes, of course I understand, but maybe we have to consider that restenosis is not such dangerous.
Of course.
That's very reasonable, but as you said, it's between Scylla and Charybdis. You don't know which way to go. With both, you have a problem. One more question, please. Yes.
Do you have mesh-covered stents like MGART in your lab, and what's your experience with it?
In our lab, we have only graft master. We use only graft master.
Very short remark. We didn't discuss about the patient himself. I've been also in charge of patients who were in detention, and we know that there is no compliance with the treatment. And how about the option of surgery? Because it's a very simple act in surgery, just to occlude and then to, because there is no stenosis. In fact, there is just.
Honestly, we are working in a center. The surgery is at 10 meters from the cath lab. And we call the surgeon in the first coronary shoot. He say, okay, it's an easy job for you, you can do it. And when we come back with acute coronary syndrome, we don't ask question, you have to go, you have to open arteries. But in the beginning, we ask the surgeon to see pictures.
So thank you very much.
You're welcome.
Great,
thank you.
and thank you also. And thank you also for entertaining questions, and this is always a good thing that we include the audience.